will be a sensitization toward basics of mechanical ventilation. So objectives of this presentation will be to, we'll see what are the different parts of ventilator and what are the terminology which are the different terms used in relation to mechanical ventilation, different modes of mechanical ventilation, indications for ventilation, and what should be the initial settings in common diseases that we encounter in pediatric critical care, and how to monitor a patient on ventilator, and what should be the supportive care, and weaning also. And without ventilator graphics, mechanical ventilation is not complete. So if there is time or if time permit, we will also discuss something about ventilator graphics also. So respiration has two parts, ventilation and oxygenation. Ventilation is basically movement of gas in and out of the lungs, and oxygenation is basically pulmonary gas exchange, that is movement of oxygen from the alveoli to the blood and transport of this oxygen through the blood to different tissues and cells for its utilization. And mechanical ventilator is a device or technique through which gas it moves in and out of the lungs by an external device connected directly to patient. So this is what mechanical ventilator is. And objectives of mechanical ventilation is to maintain adequate gas exchange, to reduce or substitute respiratory efforts, to diminish consumption of consumption of systemic or myocardial oxygen, to obtain adequate lung expansion, which is most common indication in our setting. So most common conditions which we use ventilator include pneumonia and ARDS. So this is the one indication to obtain adequate lung expansion, we use mechanical ventilation. And the second and the last objective is to allow deep sedation, anesthesia, or muscle relaxation in settings like if we are managing a child with status epilepticus and we are using anesthetic medications, or a child with tetanus, or a child undergoing surgery. So these are the different objectives of mechanical ventilation. So mechanical ventilator is basically a device which provide driving force, and it provide gases at particular flow. It generates pressure so that there is some change in volume inside the lungs. So this ventilator external device is equivalent to respiratory muscles of the human body. And then there are ventilator tubings which are connecting the ventilator with the patient, and these tubing include endotracheal tube and ventilator circuit tubing, and these are equivalent to conducting pathway of the respiratory system. And then very important component which we often forget is humidifier, which is very important component of mechanical ventilation. It include a humidifier base, a humidifier chamber, heating wires which are connected to humidifier base and the two locations, and there is a temperature probe near the endotracheal tube, and there is inside inspiratory and expiratory tubing, there is heating wires to heat the inspiratory and expiratory gases. And this whole assembly of humidifier is equivalent to our nose or nasopharynx to heat and warm the inhaled gases. So what ventilator does is it provide a pressure gradient so that there is some gas flow over some time which lead to change in volume inside the lungs. So this is the main function of a ventilator. So ventilator is a very complex assembly. It has various parts like this is a gas mixer or blender which combine air and oxygen in different proportion depending on how much FiO2 we want to give. Then this gas mixture passes through inspiratory valve, inspiratory filter, and it goes to humidifier, from where then it goes to patient through a inspiratory lib of the humidifier, this ventilator circuit. From the patient, the expiratory gases goes through the expiratory filter to expiratory valve and then to atmosphere. In between inside the ventilator, there are several assemblies of microprocessor which has a control system which control inflow and outflow of gases, how the pressure is being delivered, how the volume is being delivered, and how the flow is being delivered. And those are the things which are inside the ventilator. They are controlling, they are providing very fine control of ventilation. As we know that humidification is very important component of ventilator, but if humidifier is not available or not working, then we can even use heat moisture exchanger, which is known as HME. It is known as artificial nose. It is very simple and effective tool to use, and we can use a HME for 4 days if there is no obstruction. But in small children, it may contribute to dead space if we are using very large HME for infant or a neonate. And if there are plenty of secretion, then those secretion can pile up in HME and can increase resistance to airflow. So it can be easily used up to 3 to 4 days if everything is working fine, right? So coming to ventilator, there are several different brands or companies which are producing ventilator, and these are used in pediatric, and this is one of the high frequency oscillator ventilator, which Akash told that the lecture was already happened on this HFO mode of ventilation, and these are the few commonly used ventilator in our setting. So coming to several terminologies. So what is flow? Flow is basically it is measured as volume of fluid passed at certain point in unit time. So the formula is change in volume upon change in time. So there should be a pressure difference which should be present for a fluid to flow through a tube, and higher pressure, if the pressure difference is higher, the flow generated will also be higher. So this is formula delta V by delta T. What is compliance? Compliance is basically a change in volume per unit change in pressure. So compliance is delta V by delta P, and it indicates that how easily a system can accommodate an increase in volume or change in its shape. So compliance can be easily, we can have some idea about compliance if we see pressure volume loop of the ventilator graphic. So this is the inspiratory limb of pressure volume loop. So initial part is flat. So we can see that as there is increase in pressure during initial phase of inspiration, there is not much increase in volume. So this is the first phase of inspiration, which is having very low compliance, and most of the pressure is required to open the collapsed alveoli. But after some point, there is rapid increase in volume also with increase in pressure. So this is the loop, or this is the area of high compliance, or this is the second zone of PV loop, or inspiratory limb of PV loop. And then at the end of inspiration, again, this is the zone of low compliance. There's not much increase in the volume with increase in pressure. If this graph is like this, and now it is shifting toward right side, the slope of the graph is shifting to right side, it indicates that there is low compliance. And if this graph is shifting toward left side, that it indicates that the system has high compliance. A resistance is amount of pressure required to deliver a given flow from point P1 to P2. So it is given by formula of delta P divided by flow. So this is the formula for resistance. So these things we have already discussed, that flow by time is volume and this is flow. So coming to another important concept of time constant. Time constant is defined as time taken for a lung unit or alveolus to fill with the gas or to empty from the gas. So there is a step change in pressure is applied. The instantaneous change in there will be a very fast change in volume followed by a progressively flattened curve. So whenever we are applying some pressure, there is increased filling of alveoli in initial part, and then followed by a gas flow or change in volume, which is not very much in the later part of inspiration. So in one time constant, there is 63% of alveoli are filled with gases, or if we are considering a single alveoli, then 63% of it is filled with gas. And if we are increasing time constant to 2, 3, 4, the percentage changes to 86%, 95%, 98, and 99%. So it required 3 to 5 time constant for lung or alveolar unit to completely fill with gas or completely empty with the gas. The time constant is given by formula compliance into resistance. So what is the importance or clinical implications of time constant? So in conditions where the alveolar units are slow, it means the condition with high airway resistance, as we see in bronchial asthma or bronchiolitis, the movement of air in or out of the lung unit is slow, because you know that the airway is constricted or airway is narrow. And units with high resistance, they will require longer time constants because they need a much longer time to fill and empty. So high resistance areas or units, they have slow alveoli. These alveoli are very slow to fill and slow to empty. Whereas in conditions with low compliance like pneumonia or ARDS, the flow of air into the unit will cease soon than in other units. Like in the areas of the lung where there is low compliance, those alveoli, they will fill rapidly and they will also empty rapidly. So these are the fast alveolar units. So intubation is there are slow, we have to give low rates. If the pathology is having fast alveoli, then we can give higher rates to these patients. So we can see that in asthma and bronchiolitis, we often set lower rates for that age, whereas in pneumonia or areas, the higher as compared to the physiological rates for that particular age. Then control variables are those variables which we seek to control, and these are basically independent variables. It could be pressure, volume, or flow. So what is the control we are setting? If we are setting pressure, then it is a pressure control mode of ventilation. If we are setting volume, then it is a volume control mode of ventilation. Second variables are phase variables. These variables start, sustain, or end phase of the inspiration. So these can be remembered by mnemonic TLC. T is for trigger variable, L is for limit variables, and C is for cycling variables. So trigger mean when to start a breath. So that point is trigger or trigger. It could be time, it could be pressure, it could be flow, and it could be volume. Most commonly used trigger variables are pressure or flow, which we call as pressure trigger or flow trigger. And limit variables are when inspiration is going to end or going to reach its maximum. It could be pressure or it could be volume. So in volume mode, the limit variable is volume, and in pressure mode of ventilation, the limit is pressure. Once a limit is reached, inspiration will continue with that variable till there is till the end of inspiration. So cycling variable is the variable which determine cycling from inspiration to expiratory phase. So this is the cycling time here. It could be either pressure, volume, time, or flow. And most common variables used for cycling are either time for mandatory breaths and flow for flow cycling breaths. Like in a pressure support ventilation, we use flow as a cycling variable. Now coming to different types of breath. It could be a spontaneous breath by the patient, or it could be a mechanical breath. Again, mechanical breaths are divided into two parts, two types. It could be assisted or it could be controlled breaths. So this is a pressure time scaler. You can see that there is a PEEP which is set to start with. Then there is increase in pressure during inspiration. Then the pressure reaches maximum. And then during inspiration, there is fall in pressure. So from this graph, we can know that there is baseline pressure, then there is increase in pressure during inspiration to peak inspiratory pressure. And this time is known as inspiratory time. And then during the expiratory time, there is expiratory phase and the pressure decay to the baseline. So how to differentiate between a spontaneous versus a mechanical breath? So in mechanical breath, it means that everything is done by the mechanical ventilator and patient is not participating. So patient is deeply sedated or paralyzed. So this is how mechanical breath look like in pressure time scaler. So there is no trigger here. The ventilator has started the breath and the ventilator had cycled to expiration. So this is how a mechanical breath look like. But if there is spontaneous breaths, then due to spontaneous efforts, there is negative deflection in pressure. So this negative deflection is basically trigger, and then it is inspiration in the negative direction and expiration in the positive direction. You know that during spontaneous breathing, we create negative interthoracic pressure, and during expiration, we create positive extrathoracic pressure. So this is a purely a spontaneous breath without support from the ventilator. So how to differentiate between assisted and controlled breath? Controlled breath we already saw in the last slide. And in assisted breath, so what is happening is patient is starting the breath, but ventilator is supporting that breath. So this is assisted by the ventilator, but triggered by the patient. So this, you can see her trigger here, negative deflection, and then pressure rises, and then there is fall in pressure. This pressure is supported by the ventilator. So this is assisted breath, right? If there is CPAP, then there will be continuous positive airway pressure will be maintained throughout the respiratory cycle, and patient can breathe on the given CPAP. So this is CPAP mode of ventilation. Coming to different modes of ventilation, so the ventilation has evolved over the time. So what was used in initial days was controlled mandatory ventilation or continuous mandatory ventilation, where the work is done by ventilator and patient used to be heavily sedated or paralyzed. Then there is intermittent mandatory ventilation, when the patients are allowed to breathe in between without any support from the ventilator, except for mandatory breaths. Then synchronized intermittent mandatory ventilation, then pressure support. The combination of both two is SIMV with PS. It could be of two types, either pressure controlled or volume controlled. So this is the which is most commonly used these days in Indian settings. Most people use pressure control mode of ventilation like PC, SIMV with PS. But in adults, they often use volume control mode of ventilation. Then there is CPAP, or airway pressure release ventilation, or high frequency oscillatory ventilation. So there are several different modes are there. So this is continuous mandatory ventilation. This is pressure time scaler. So you can see that there is no trigger. The work is done by ventilator. Ventilator is triggering and ventilator is cycling. So there is no patient efforts, and patient used to be heavily sedated, paralyzed, and there is no spontaneous breathing allowed. Not used these days because this is not physiological mode of ventilation. Then the ventilation modes has evolved over the time. This is intermittently mandatory ventilation, when there are certain mandatory breaths which ventilator will deliver, but in between the mandatory breaths, patient can take spontaneous breaths also. Then there is synchronized intermittent mandatory ventilation. Synchronized word mean that there is a particular time window. If the patient initiate breath within this time window, then the patient will get pressure set on the ventilator. But if patient fail to initiate the breath during this window, then the ventilator will deliver a mandatory breath. And in between also, patient can take spontaneous breaths. Then comes SIMV with pressure support, which is addition of pressure support to this form of ventilation. So here it is same as SIMV, but the spontaneous breaths of the patient will also be supported by the ventilator. But these spontaneous breaths will be patient triggered, patient cycled, but will be assisted or supported by the ventilator. Purely a pressure support ventilation mean all the breaths will be initiated by the patient, and whatever breaths he is taking, they will be supported by the ventilator, right? The pressure control ventilation, what is limit variable is peak inspiratory pressure, and we can also control inspiratory expiratory ratio here, and precise pressure alone may not produce satisfactory tidal volume. So in conditions like if the lung condition is worsening and we are not changing the pressure, then the tidal volume will goes on decreasing. But if the lung condition is improving, then if we are not changing the pressure, then tidal volume may goes on increasing with improving lung compliance, and it can contribute to volume trauma. So this is problem with ventilation. We have to adjust pressure based on the clinical condition of the patient or based on trajectory of the patient. In volume control ventilation, we can precisely control only volume, but the pressure delivery may be inconsistent. In certain situations, if there is worsening in the lung condition, or there are secretions in the circuit, or if the child is coughing, then very high pressure which can add to. SIV mode of ventilation provide better patient-ventilator interaction. There is less interference with normal cardiovascular function, and there may be sometime increased work of breathing, right? In pressure support ventilation, it is more patient-friendly. Patient will be comfortable. There will be improved patient-ventilator interaction, decreased work of breathing, and apnea backup rate has to be set, because if patient stop breathing due to some reason, then there should be a backup rate, or there should be an alarm. When to start mechanical ventilation? So common indications are ventilation abnormalities like respiratory muscle dysfunction or neuromuscular diseases, decreased ventilatory drive common in CNS disorders, increased airway resistance or airway obstruction, And oxygenation abnormalities include refractory hypoxemia, if there is need of PEEP as in patients with pneumonia and ARDS, or if there is excessive work of breathing due to any other cause. So ventilator circuit, before setting ventilator, we should have a knowledge about which type of ventilator circuits we have. It could be a reusable circuit, or it could be a single use or disposable circuit. So whenever we are assembling the circuit, we should have we should follow strict aseptic precaution. We should wear a gown, cap, mask, and gloves so that sterility can be maintained. The initial setting of the ventilator depend on the nature of the support we need, which in turn depends on underlying pathophysiology. And there are no preset parameter for all the patient or for all the disease condition. The primary goal is to maintain adequate oxygenation ventilation, reduce work of breathing, and maintain an adequate synchrony between patient and ventilator. So the initial settings should be guided by the resistance and compliance by hand ventilation. Then we should choose a ventilator mode. We should avoid very high inspiratory pressures, like if it is the target should be limit peak inspiratory pressure to less than 28 or 30 centimeter of water. We can start with a higher FiO2, but it should be titrated downward to maintain saturation targets of 92 to 94%. And very high FiO2 should not be used for very long period of time. So initial settings, these are the few parameters which we set on the ventilator. So if we are using volume control mode of ventilation, then we should use tidal volume of 6 to 8 ml per kg to have adequate chest expansion. If we are using pressure control mode of ventilation, then we need to set PIP as well as PEEP. The normal physiological PEEP is 13 to 15 centimeter of water, and PEEP is 3 to 5 centimeter of water. I ratio normal is 1:2 to 1:3, and inspiratory time should be determined by the time constant, which is product of compliance and resistance. The ventilator rate should be normal for age or based on what kind of physiology we are dealing, whether it is slow alveolar units or fast alveolar units. And FiO2, we can start at higher FiO2, but we should titrate it to as low as possible to maintain our target saturation. And trigger sensitivity, it is like it could be a pressure trigger or flow trigger. Flow trigger is a preferred mode of trigger sensitivity, and for infants and neonates, the commonly used trigger sensitivity is 0.5 to 1 liter per minute. For older children, it is 1 to 2 liter, and for adolescents, 2 to 5 liter per minute. So these are the basic physiological parameters or ventilator parameters which we have to set on a ventilator. So coming to pneumonia, ARDS, so we know that there is it is a heterogeneous disease. There is diffusion defect, VQ mismatch, lungs are stiff, and these are the fast units. So these things we have to remember. So we can use either pressure control mode of ventilation or volume control mode of ventilation, and this is the common mode which we are using these days. Pressure control SIMV with PS. So what are the parameters we have to set if we are using pressure control mode of ventilation? We have to set PIP, and using volume control, we have to set rate, trigger, inspiratory time, FiO2, and PEEP. So let's take example of 2-year male child, 10 kgs with ARDS. So we are using PCSIV with PS. So PIP is 15. It is delivering tidal volume of 60, which is like 6 ml per kg. PEEP set is 8 because we know that this is a low compliance lung which may need higher PEEP. Rate is 30 per minute. I ratio is 1:2. FiO2, we are starting with 60%, but we know that we have to decrease it as soon as possible. Trigger is 2, and pressure support of 12 for the spontaneous breaths, right? So this is a ventilatory setting for pneumonia and ARDS. And what monitoring we should use or how to type patient. So it should be a clinical monitoring as well as several parameters like SpO2, EtCO2, ABG, and pressure volume loop. So the pressure volume loop is very important to monitor. If this loop is coming or it is going toward the right side, it means there is worsening of the lung or there is decrease in the lung compliance. But if there is a shift of this loop toward the left side, it means that there is improvement in the compliance. So we should consider lung protective ventilation strategies whenever we are ventilating a child with ARDS. We should limit peak pressure to less than 20 centimeter of water, tidal volume should be 6 ml per kg, FiO2 should be less than 60%, and driving pressure, which is difference between P and PIP, it should be less than 15 centimeter of water. And we can allow permissive hypercapnia. We can tolerate a little bit higher CO2 if pH is more than 7.25, and we can also tolerate permissive hypoxemia to maintain saturation of 88 to 90%, so that we overshooting our limit of less than 20 to 30 centimeter of water of peak pressure. How to ventilate a child with asthma or bronchiolitis, which we know that it is a conditions with increased airway resistance, and these are slow alveolar units. So in this condition, commonly used mode is pressure control mode of ventilation with SIMV and PS, and we are not comfortable in using volume control. In this condition, if we are setting volume, then very high pressure can be delivered by ventilator, which can lead to barotrauma. So again, we have to set PIP, rate, trigger, TI, FiO2, and PEEP. We know that there is VQ mismatch, air trapping, the resistance is high, and the alveolar units are slow. So we can take example of a 2-year male child, either it could be asthma or bronchiolitis. The setting is PCSIV with PS, or we can use pressure support alone. PIP is 10, PEEP is 5, rate is 16, right? So these are slow units, so we are keeping a rate of 16, and I ratio is 1:3, because we know that we have to keep longer time for expiration, because during expiration air resistance further increases. So we are increasing expiratory time little prolonged than inspiratory time. FiO2 is 40%, trigger is 2, and pressure support is 8 centimeter of water. So for monitoring in this condition, in addition to clinical SpO2, EtCO2 monitoring, ABG, flow volume loop monitoring is very important. So this is flow volume loop on the y-axis, and volume is on the x-axis. So this is the inspiratory part, and this is expiratory part. So this is how a normal flow volume loop looks like. But if there is bronchospasm or increased airway resistance, the expiratory flow or peak expiratory flow rate is decreased. So there is decrease in peak expiratory flow rate. There is concavity in the expiratory lobe of flow, but this is not reaching zero. So there is some amount of air trapping which is happening. So this is a flow loop of bronchospasm. And if we are giving therapy, or there is improvement in bronchospasm with bronchodilator therapy, we can see that the return of flow volume loop toward a normal shape. Patients with or encephalitis where the lungs are normal, so we can use either PCSI mode of ventilation or VCSIV with pressure support. There is normal lungs, but we know that there is alveolar hypoventilation. We have to just support the work of breathing, and all the parameters should be normal as per his child's age and weight. So we can use normal rate for age, use inspiratory time of TI ratio of 1:2, FiO2 as, and physiological PEEP of 3 to 5 centimeter of water. So any child with normal lungs, these are the usual ventilator settings. So we have discussed this already. So what are the determinants of oxygenation and ventilation? So if there is any problem with oxygenation, we have to increase mean airway pressure, which depend on peak inspiratory pressure, positive and expiratory pressure, inspiratory time. So these are the three factors which determine MAP. So we can increase these three factors within permissible limits, and if none is working, then we can increase FiO2. But if there is problem with the ventilation, we can increase respiratory rate and tidal volume. We can increase expiratory time, and we can avoid dead space. Like if there are any dead space in the circuit, we can remove that, right? So how to monitor a child on ventilator? Clinical assessment is very important. Oxygen saturation, chest X-ray after intubation, blood gas to see for oxygenation and ventilation status, pulmonary mechanics. We can have some information about pulmonary mechanics if we are seeing air entry, chest expansion, lung volume, compliance, resistance, these are the numbers which are there displayed on ventilator. Adequacy of gas exchange, we can have some idea about SpO2, PO2, or saturation. Adequacy of ventilation and ventilator function, we can know what is the tidal volume, what is minute ventilation, PIP and MAP delivered, and values from EtCO2 and arterial CO2 see for adequate. Whenever there is acute deterioration of ventilator, like there is fall in saturation, cyanosis, fall in blood pressure, we should rule out DOPE, that is displacement of the tube of pneumothorax, and equipment failure. So these are the common causes of acute deterioration on a ventilator. However, when there is gradual deterioration, then these are the common condition like inspiratory excretions in the tube or in the airways if you are not using humidification properly. There may be diffuse segmental or subsegmental atelectasis. There may be developing pneumonia or pulmonary interstitial emphysema, worsening lung parenchyma disease, or onset of chronic lung disease. So these are the things we should keep in mind if a child is having gradual worsening on ventilator. Uh, Whenever patient has poor asynchrony with the ventilator, or we see that patient is fighting ventilator and developed increased work of breathing like intercostal retraction, tachypnea, tachycardia, increased abdominal chest wall movements, then the common cause is related to tube. It could be a blocked tube. There may be excretions in the tube. So most common cause we have to look into the endotracheal tube. And sometimes ventilator may be not functioning, so we should rule out these two things. Then we can check about the phase variables, that there may be inappropriate trigger, there may be inappropriate pressure or volume set, or there may be cycling asynchrony. So these are the important variables which check if there is any patient asynchrony. There may be auto peep, as we saw in condition with in example that I showed of so they may peep, analgesia. So all these checklist has been whenever patient is fighting. Supportive care during ventilation, pulmonary hydrotherapy, drainage, proper important. We should avoid overload. Nutrition care should be taken care. We should start nutrition as early as possible and prevent off by using web bundle like regular hand hygiene. Head of the bed should be elevated to 30 to 40 degrees. Oral hygiene with chlorhexidine mouthwash. We pharyngeal secretion regular for endotracheal tube suctioning. We should avoid over-sedation, and we should give daily breathing, stopping sedation for few hours and see if the patient is, and we should liberate from the ventilator as soon as possible. So that should be our aim, to liberate a child from mechanical ventilation as. So there may be several complications in a child who's on ventilator. It tube related to FiO2, pressure or tidal volume. It lung injury due to barotrauma, volutrauma, or atelectotrauma. There may be long-term complications like fibrosis or increased air resistance and vascular changes. When reduced lung injury could be due to increased pressure, increased volume, atelectotrauma, collapse of alveoli at certain areas. There may be shear stress due to repeated opening of alveolar units. There may be biotrauma due to various chemical mediators which are released during mechanical ventilation, and there could be oxygen toxicity. So several factors contribute to lung injury. Weaning from ventilation is very important, and we should start weaning, or we should start thinking about weaning as soon as we put a child on ventilator. If there is any clinical improvement in SpO2, ABG, respiratory distress, in clinical condition for which child was intubated at started on mechanical ventilation, from the natural disease idea that when this child is going to be extubated. So example of pneumonia, we know that in next 4 to 5 days pneumonia is going to improve, and that is the time we are planning to extubate or wean a child and then extubate a child. Children with neuromuscular diseases, we know that they take very long time to recover, so longer ventilation is needed. When adequate oxygenation, cardiovascular stability, fluid status is adequate, these hemodynamic parameter or hematological parameters are okay, there is no sepsis, no fever, nutrition is adequate, then the child is ready to wean from ventilator. We should stop sedation, check neurological status about power, cuff reflex, and give a spontaneous breathing trial for 2 hours to see if the patient is able to breathe spontaneously for 2 hours. So how to reduce ventilator setting during weaning? So we should reduce most noxious parameter first. So we should try to come down on PIP first, FiO2, PEEP, and ventilator rate. and which should change one parameter at a time. The change should be small in numbers, like we should decrease pressure by 1 to 2 centimeter at a time, by 5%, and respiratory rate by 2 to 4 per minute. Assess after each change before changing next parameter or before going on to. So it should be clinical assessment, monitoring of saturation, carbon dioxide, blood gas, and chest X-rays, depending on clinical condition. So weaning could be slow or it could be fast. So we know that condition which improve rapidly, like pneumonia, aspiration pneumonia, bronchial asthma, bronchiolitis, neurotoxic snake innovation, these patients can be from the ventilator, whereas conditions with neuromuscular disorder which take longer, they need slow weaning. So extubation protocol: start dexamethasone 0.515 mg per kg, 4 doses give pre-extubation and 2 doses post-extubation to stridor. Keep child nil per oral, check line, keep intubation tray ready in case reintubation is needed. Suck oropharynx, lose the last of we have used to fix the tube to the patient's face, and then remove the respiratory phase. Some people also use ambu bag while removing the endotracheal tube. Post-extubation care, we can put child on PAP or oxygen depending on the condition. Child should be kept on upright or semi-recumbent position. Oropharyngeal sectioning should be done regularly, and we should monitor clinical parameters. And Westlake Group score is important parameter to detect upper airway obstruction. We can do ABG after 1 hour and chest X-ray after 4 to 6 hours. If there is croup, if there is stridor, we can give adrenaline ablation. And after 4 to 6 hours, if everything is okay, we can start. Right? So there may be certain causes which can cause flare, like respiratory muscle strength in condition with diaphragmatic weakness, critical illness, neuromyopathy, malnutrition, electrical abnormalities, and prolonged use of neuromuscular blockers. If there is airway narrowing due to laryngeal edema, if the ventilator requirement is still persistent, pneumonia, collapse, chronic lung disease, or ventilator-associated pneumonia, or paralysis of respiratory muscles due to peripheral causes or central causes. So these are the several parameters which we should consider whenever there is weaning failure. So how to avoid mechanical ventilation? So this should be very important aspect in critical cares, that we should see if we can avoid mechanical ventilation. And positive pressure ventilation is not equivalent to invasive mechanical ventilation always. We can use non-invasive ventilation, and I suppose that that topic has already been covered. So it could be nasal bubble CPAP, HHFNC, non-invasive ventilation. So predictor of success in a non-invasive ventilation include disease is less severe, there are no comorbidities, the interface is tightly fitting with no air leak, and there is response within 1 or 2 hours of NIV. If these are the parameters, then we are sure that non-invasive ventilation is going to succeed. So common conditions where non-ventilation can be used are bronchiolitis, asthma, pneumonia, hemato-oncology, and during weaning. So we have discussed about mechanical ventilator, various physiological parameters that need to be set during mechanical ventilation, how to see the child is ready for weaning, how to wean a child, and how, right? So ventilation part is over. So if we have some time, we can discuss about ventilator graphics, which are also very important component of ventilation. So Dr. Akash, do we have maybe minutes to graphics?
We can continue.
Yeah, okay. So graphics are basically graphical display of parameters. So these are divided into scalars and loops. Scalars are 3 types: pressure time scalar, and flow time scalar. So parameters are plotted against time. So these are scalars. And we have 2 types of loops. It could be pressure volume loops, flow volume loops. We call them loops because these 2 parameters are plotted against each other, and the point where inspiration start is the same point where the expiration end. They form the loop. So this is the reason why they are as loops. So this is a flow time scalar. There is difference in the shape of flow time scalar during volume control and pressure control mode of ventilation. So in volume control mode of ventilation, the inspiratory part of the flow is square wave constant flow pattern. So this is the square wave constant flow pattern of inspiratory flow pattern in the volume control mode of ventilation, and expiratory phase negative like this. Okay. However, in pressure control mode of ventilation, the shape of inspiratory flow pattern is variable decelerating. So there is maximum flow at the start of inspiration, and then there is decelerating flow, and expiration is again negative deflection. So this is important difference between volume control, control mode of ventilation in a flow time scaler. Pressure time scaler. So pressure is plotted on y-axis, time on x-axis. So again, there is difference between volume control and pressure control mode of pressure time scaler looks different. In pressure control mode, the pressure time scaler looks square shaped. There is rapid increase in inspiratory time. There is rapid increase in the set pressure, that is peak inspiratory pressure, which is maintained during the duration of inspiratory time, and then there is fall in pressure to the baseline pressure during which is maintained during the expiration or expiratory time. However, the volume control mode of ventilation, there is a linear increase in pressure till the peak inspiratory pressure is reached, and then there is fall in pressure to the plateau pressure during the inspiratory pause, and then from the plateau pressure the pressure decreases to baseline during expiration. So again, pressure time scaler is different, having different shape in volume control and pressure control mode of ventilation. So the pressure time scaler, what information we get, we can have information about PEEP in pressure, what is the trigger, or is it a spontaneous breath, assisted mandatory breath. We can see how rapidly pressure is rising, peak inspiratory pressure, what is inspiratory time, what is the expiratory time. So we can get a lot of information from pressure time scaler also. So we can have information about peak inspiratory pressure, plateau pressure, airway resistance, and compliance from the pressure. This is the flow time scaler. So inspiration is positive and expiration is negative deflection. So this type of flow is characteristic of pressure control ventilation. So this is the decelerating variable flow. So this is the zero flow, increase in flow to maximum, which is peak inspiratory flow rate. Then there is variable decelerating flow, and flow is again coming to zero during end of inspiration, and during decay of flow to peak expiratory flow rate, and then it slowly comes to baseline. So these are different components of scaler. What information we get from the flow time scaler? Information about inspiratory and expiratory time. What is peak expiratory? Is there any prolongation? Is there any this volume time scaler? Volume is plotted against time. So this is inspiratory phase when the tidal volume is increasing, and this is the expiratory phase when the tidal coming to baseline. So from the volume time scaler, we can have some information about how much tidal volume is being, and if there is any leak in the circuit. So if there is, then the expiratory part will suddenly fall baseline without going like a slanting line. So if it like this, if it is like this, it means there is this amount of leakage there in the circuit. So in a child with poor compliance or ARDS, how we can identify that? So the pressure time scaler, the plateau pressure will increase from the baseline. We will increase. There may be less distance between PI and plateau. So overall size of the pressure time scaler increases. So this suggests that there is low compliance. If the patient is on pressure support or pressure ventilation, then there will be fall in the tidal volume if we are not changing pressure. In conditions with increased resistance, so there will be increase in peak inspiratory pressure, the remain normal, and there is increase between peak inspiratory pressure and plateau pressure, which suggests that there is increased resistance. And in the flow time scaler, we can see that there will be decrease in peak expiratory flow rate. The expiration may be prolonged. There will be scooping of the expiratory limb of the flow time scaler, and sometimes we can also see that there is tapping and the flow is not reaching baseline before the start of next inspiration. We can also see to treatment in patients with increased airway resistance. Whenever we give bronchodilators, so there will be increase in peak expiratory rate, shortening of expiratory time, and slope of the expiratory phase become more. So it indicates that there is response to treatment. Tapping in flow time scaler will be seen like this. So the flow is not returning to baseline before the start of next inspiration. So this is air trapping or auto PEEP. If there is inadequate sensing, so some of the effort will not be supported by the ventilator, and if the patient produces enough trigger, only those efforts will be supported. So it could happen if the patient efforts are not enough to trigger the breath, or if the trigger set is very high. So treatment for this condition is to set appropriate trigger, and flow trigger is better than pressure trigger. If there is excessive secretions in the circuit, or if there is leak in the circuit with leading to loss of PEEP, or if the trigger is too sensitive, then there will be auto cycling or auto triggering. They will be there. So multiple breaths will be there, which is not a set rate, but patient is triggering multiple times due to all these conditions. So we have to treat the cause. If there is inadequate ventilatory support, it can lead to flow asynchrony. So what is happening here in this graph, that this flow or this pressure is not sufficient for the patient. So patient has started a breath, but during inspiration, patient is again starting or again taking a effort to increase more flow in the circuit, which is leading to fall in the pressure in the inspiratory part of the pressure. So there is scooping in the inspiratory part, and there may be ultimate increase in pressure to generate more tidal volume. So if you are seeing a deflection or or scooping in the pressure time scaler, so that there is inadequate flow. So we have to increase the flow. If we are ventilating on a volume control mode of ventilation, we can change to variable decelerating flow pattern, or we can increase pressure in pressure control mode of ventilation. So if this inadequate flow or flow asynchrony increases further, then patient may take a second breath during the same breath which he had initiated. So this is double triggering, which is again due to insufficient flow. So if there are secretions or condensation in the circuit, then you can see multiple serrations or sawtooth appearance of expiratory and inspiratory part of pressure and flow time scaler. Coming to pressure volume loops. So this is the characteristic pressure volume loop. This is the inspiratory part of the pressure volume loop, and this is expiratory part. We already discussed that inspiratory limb has three parts: lower compliance phase initial part, then there is high compliance, and at end of inspiration, there is again a low compliance phase. So we can have some information about the compliance. So if there is a rightward shift of the PV loop, it indicate that there is decrease in compliance. But if it is leftward shift of the PV loop, it indicate that there is increase in compliance. We can see over distension, or it is seen as a weakening of the terminal part of the inspiratory limb of PV loop. It is commonly seen if we are setting too high tidal volume or too high pressure. It can lead to several harms like increase in dead space ventilation, increased pulmonary vascular resistance, hemodynamic complications or compliance, and volume trauma. So to overcome this, we have to decrease tidal volume or peak inspiratory pressure, and we can optimize PEEP. This is how a leak is seen in pressure volume loop. So the volume is not returning to baseline at end of the expiration. So this amount of volume is leaking somewhere in the circuit. We can have some information about work of breathing. So if there is increase in the width of PV loop, it indicates that there is increased work of breathing. This is the characteristic flow volume loop where the flow is plotted against the volume. So this is inspiratory part. During inspiration, there is increase in flow, and at end of inspiration, it baseline. And then during expiration, there is rapid decay of flow to the peak expiratory flow rate, and then there is gradual baseline, right? If there is air leak, then this flow will not return to baseline, and this much of flow has leaked somewhere in the circuit. If there is air trapping, it's not returning to baseline, but it is ending over here, and this much of volume is retained inside the lungs. So this is how air trapping looks in flow volume loop. If there is obstruction, so this is how a flow volume loop looks, there is decrease in peak expiratory flow rate, there is increase concavity of the expiratory limb, there is prolongation, or sometimes there may be air trapping. So these are the characteristic features of airway obstruction. If there are excretions, they are seen as serration in flow volume loop. So to conclude, we should have an understanding about what type of ventilator we are using, which type of tubing we are using, what terminologies, common terminologies we discussed, and important, which mode of ventilation we are using. When to initiate mechanical ventilation is very important, but at the start of ventilation, know that when we are going to wean a child on the ventilator. Initial setting should be based on the compliance, resistance, and of the disease. Humidification is very important, should be must in a child who's on mechanical ventilator. Even during NIV, we should use humidification. Oxygenation is guided or determined by mean airway pressure and FiO2, and CO2 removal is determined by alveolar ventilation. Weaning plan should be made right at the start of initiation of ventilation. Spontaneous breathing trial daily unless they are